Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a very important a case that you might encounter in your daily practice with implications on the diagnosis and the management. Gliomatosis in the peritoneum and nodal gliomatosis in a patient with immature ovarian teratoma. So this is a case of a 23-year-old female patient who presented with abdominal pain and was found to have a large ovarian mass that was excised. And on examination of the sections taken from the mass, as you can see, one of the sections showed this immature neuroepithelium or a neuroectodermal element in the form of several multi-layered rosettes that on high power magnification beautifully showing the fibrillarity of the processes around the vessels, and then the multi-layering of the immature neuroectodermal cells or neuroepithelial cells. There is another one here, and then some neuropil in the background. Now, this appearance is consistent with immature neuroectoderm. This is the defining feature of immature teratoma, whether this is in the ovary or otherwise in other places. And remember that the ovarian tumors are graded according to the amount of the immature neuroectodermal component at low power magnification. So in this case, there were more than 3 foci at low power magnification of the immature neuroectoderm. Thus, the case was graded as a grade 3 immature teratoma. There were other areas showing mature components in the form of squamous epithelium, adnexed structures, again, squamous epithelium, some bone formation, endodermal elements in the form of a glandular component, and then a cartilaginous component. So all the components, the other components, were mature apart from the immature neuroectodermal component put together, and in a quantification of the immature neuroectodermal component, this was a grade 3 immature teratoma. Now, the omentum, as you can see here from the gross, it was really studded with those small nodules that on examination revealed the mature, now we're talking about mature glial component. So unlike the immature neuroepithelium that was present in the ovary, this is mature glial component, and on high power magnification, you can see the fibrillarity again, the kind of spindle cells with the processes, but really no evidence of immature element. This is extremely important. And this component stains with GFAP, beautifully delineating the nodules that really correlates with the nodules seen grossly. But what was interesting in this case as well is that with the lymph node, pelvic lymph node dissections, one of the lymph node displayed this, again, fibrillary acidophilic component that was positive with GFAP immunostain, and this is on high power magnification, very similar to the component, excuse me, that was present in the glioma, in the peritoneum, we have the fibrillarity, the mature looking epithelium, and again on GFAP immunostain, this is the positive staining. So this was consistent with nodal gliomatosis, a rarely described entity. So the peritoneal fluid as well, and the cell block performed from peritoneal fluid revealed also evidence of a gliomatosis that was further highlighted with GFAP immunostain. So put together, this is the ovarian mass showing immature neuroectodermal component. Now, just to highlight that this component, if stained for GFAP, it's negative. So the neuroepithelium in the ovary is GFAP negative. This is the gliomatosis peritonei. This is the nodal gliomatosis, and this is the GFAP immunostain that highlighted the nodal gliomatosis, but also is positive in the gliomatosis peritonei, but not in the immature component in the ovary. Now, the final diagnosis in this case was ovarian immature teratoma grade 3 with gliomatosis peritonei and nodal gliomatosis. An issue here comes really, which is very important, how to stage these tumors. As per the WHO classification, because of the presence of involvement of the peritoneum as well as the node, this is considered to be stage 3, PT3N1, which corresponds to FIGO stage 3. However, remember that the grade for the gliomatosis, whether this is in the peritoneum or in the node, is grade 0. So although we grade the ovarian according to the immature component, the gliomatosis peritonei and the nodal gliomatosis is also given a grade 0. However, the stage is considered to be stage 3. Yet you have really to communicate with your oncologist, with your gynecologist, in order to emphasize that also, although the grade is the stage is a stage 3, yet the case should be treated conservatively because the gliomatosis component is considered to be benign. I hope you find this tip useful in your daily practice. Thank you.